Investigations in this system. And the first and the most important is USG, sonography. What sonography will tell you? Very simply, in hepatobiliary system, I should tell you, 1, it will give you hepatitis, hepatomegaly, cirrhosis of the liver, early changes, late changes. And all these are confirmatory. There is no need of any scan or anything else. Getting it? Yes. It can give you cholelithiasis. It can give you CBD obstruction. CBD obstruction, common bile duct obstruction. It can give you idea about ampulla of Vater. The ampulla which opens in the intestine. That is known as ampulla of Vater. Ampulla of Vater is the last part of the pancreatic duct. Getting my point? Yes. Now it will give the dimensions of CBD. Normal CBD is about 6 mm in diameter. CBD diameter can also be calculated on USG. Related to hepatobiliary I am talking. Are you getting the point? What you will not get properly on USG is pancreas. Pancreas head is okay. But the body of the pancreas and tail of the pancreas are not visualized on USG. You can comment some part on the head of the pancreas. Head of the pancreas can be commented by USG. But details of pancreatitis may not be properly found on USG, and for that you have to rely on only scan. CT scan will give the best idea about pancreatitis and related things. Am I right? USG is the most important tool in hepatitis. Hepatitis, jaundice, then cirrhosis of the liver, alcoholic liver disease. I will show you. Many pictures are there with me. FNAC guided by USG. See, my dear student, to be very frank with you, we generally define even cirrhosis of the liver directly on the USG, not going for any FNAC. But yes, ultra modern hospitals are there. They generally go for FNAC. FNAC stands for fine needle aspiration cytology. Fine needle aspiration cytology. It's a very simple technique. We go with the USG and we find out which part of the liver you need to assess. Then with giving the lignocaine, you can pass the needle and USG will give you where your needle is passing. If you reach at the appropriate place, you can suck the material. And that material you can go for biopsy, send for biopsy. And that's why the famous words are FNAC guided by USG for biopsy. FNAC guided by USG for biopsy. Are you getting my point? Yes. So this is the technique the people are using. It's a good technique. FNAC is not a big procedure, but generally followed by the big hospitals, ultra modern hospitals. Suppose the patient is coming to my clinic, is alcoholic, I know, and he is having the changes of cirrhosis in the liver. I may not ask my patient to go for FNAC. That is not needed for my diagnosis, neither for any confirmation. Are you getting my point? Now he is thinking, sir, I should tell you that thing also. In hepatitis B, especially in the latter stage of hepatitis B, many patients of hepatitis B convert into carcinoma. This is a very important thing I told you. Especially in the hepatitis B, many patients of hepatitis B in the terminal stage convert to CA, hepatocellular carcinoma. Now you want to define whether this is hepatocellular carcinoma or just cirrhosis. That makes no difference. Patient cirrhosis ने पण मरणारच आहे आणि कॅन्सरने पण मरणारच आहे. पण अल्ट्रा मॉडर्न हॉस्पिटल असं नाही करणार. ते काय करतील? They will go for analysis. And then they will tell you that no, now the cirrhosis has proceeded to cancer. Now it is hepatocellular cancer. Now these medicines are available. Can we give? They depend upon the patient, natevaik and relatives of the patient and condition of the patient and most important financial status. Financial status matters our country. Some GIT investigations may be repeated according to the need of the condition. काय गॅस्ट्रोस्कोपी वगैरे इफ यू रिक्वायर, आता मला पेशंटला आहे सिरोसिस, माय पेशंट इज हॅव्हिंग सिरोसिस, बट आय वॉन्ट टू चेक वेदर द माय पेशंट इज हॅव्हिंग esophageal varices or not. What is the option to me? I want to check esophageal varices. I can go only with scopy. Actually, no one goes with the scopy because that will burst. But if you want to check it, by having the option of gastroscopy. Now, this is general anatomy, but many times our anatomy is so dangerous, so that I thought that I should tell you anatomy also within 5 minutes. All of you know, my dear student, this is the liver. Am I right? Yes. This is the gallbladder. Now, important point, this is the cystic duct. This is common hepatic duct. This is common hepatic, this is cystic. This is common bile duct. Are you getting my point? Cystic duct, common hepatic duct, common bile duct. This is ampoule of Vater. Where it opens, sphincter is there. That sphincter is known as sphincter of Oddi. Sphincter is there. That sphincter is known as sphincter of Oddi. Yes. Ampulla is there, ampoule of Vater. This is ampoule of Vater and this is pancreatic duct. This is pancreas. This is pancreatic duct. This is common bile duct. Opening in duodenum. First 3 centimeters of the duodenum. Then this is left hepatic duct. This is right hepatic duct. This is common hepatic duct. Right hepatic, left hepatic, common hepatic plus cystic duct. Gallbladder ची जी duct आहे तिला cystic duct म्हणतात. Cystic duct that forms common bile duct. Common bile duct will bind to pancreatic duct and they both will open in small intestine, that is duodenum. Opening is by ampulla of Vater, controlled by sphincter of Oddi. This is the general anatomy that you should know. Now I should tell you one thing. This is the pancreas. That is totally behind the stomach. And that's why echoes you may not get properly. Because when you want to take the echoes, you will get the echoes of stomach. And that's why you can visualize this part, small this part. Middle major portion is not visible. And that's why we always say very simple words. Pancreas is ill visualized on USG. Pancreas is ill visualized on USG. If you want to take clear idea about the pancreas, scan would help you. And HD scan is really a wonderful thing available today. High density scan. Now I am going to tell you a very important thing. Now, all of you know what is the smallest functional unit of the kidney? What is the smallest functional unit of the kidney? Nephron. The same way, the smallest functional unit of the liver is known as liver lobule. I am going to repeat. The smallest functional unit of the liver is known as liver lobule. It's a hexagonal structure. It's a hexagonal structure. Can you see the hexagon? Can you see this hexagon? I may not be able to make the structure properly. I am just trying to show you. हे असं काहीतरी जोडतात ते नेमकं मला नाही येणार. असा तो बॉक्स आहे. hexagon. Getting it? Yes. Now within the hexagon there is a central vein. And the other veins coming from the GIT, their micro and the micro vessels are entering to it from its side. Are you getting my point? They are entering from all sides. Now, my point is important. Suppose I made a small part of it like this. त्या हेक्सागोनचा मी एक पार्ट घेतला असा. ही सेंट्रल वेन आहे. मी हा एवढा पोर्शन काढला. कळतंय का मला काय म्हणायचं? तो असा तयार होईल. हा तो सेंट्रल वेनचा पोर्शन आहे आणि हा तो हेक्सागोनचा पार्ट आहे. हा कुठून काढला मी? इथून. आणि त्याला असं चिटकवलं आहे. कळालं का प्रत्येकाला? म्हणजे पूर्वी ते असं पिंप होतं, पिंप. त्याचा मी वर षटकोनी भाग काढला, एक षटकोन काढला. पूर्ण षटकोन होते, सहा कोण होते त्याला. त्यातला एक कापला आणि त्याला असा चिटकवला आहे. आता काय दिसतं ते फार महत्वाचं आहे. हे काय आहे? पोर्टल सर्क्युलेशन आहे सगळं. ब्लड येतं आहे आतमध्ये. दॅट इज अ ब्लड दॅट इज बिंग collected from GIT. That will come to liver. That is what we call portal circulation. The portal circulation will expose to the liver. These are the hepatocytes. Can you see the hepatocytes? Now the blood will be coming from the GIT and is being exposed to the liver, and finally it will move to the central vein. Now my point is important. This is how the portal circulation, after exposing to the liver cells, get converted into systemic circulation. Because central vein is a part of systemic circulation. It ultimately drains the blood in inferior vena cava. Because it is the hepatic part of the hepatic vein. यातून पुढे काय तयार होणार? हेपॅटिक वेन. हे बघ झाली. ही सेंट्रल वेन आहे, ही हेपॅटिक वेन आहे. The hepatic vein pour its blood into inferior vena cava. Try to understand a very big thing I am telling you. Blood is being collected by GIT. It will get exposed to the liver. After exposing to the liver parenchyma, the blood will be moving to the central vein. Central vein pour its blood in hepatic vein, and hepatic vein ultimately is a part of inferior vena cava. This is how portal circulation converts to systemic circulation. This is how portal circulation converts to systemic circulation. Are you getting my point? Now I am telling you a very important thing. Let's see. Now point is important. These cells are dying. They are dead, and they form fibrous tissue. These cells are dead and the liver has become shrunken. Getting it? And fibrosed. That is what is known as cirrhosis of the liver. Now tell me, my dear students, whether the blood coming from the portal vein enter the liver properly. Whether the blood coming from GIT will be received by the liver properly or not. Will the liver receive the blood? No, my dear students. It may not be able to receive whatever the quantity of the blood is coming. Partially it will reduce. Partially it will take. Am I right? Partially it won't. Then tell me, my dear students, where the blood will accumulate. When liver is fibrosed, liver cells are dead, regeneration doesn't take place, replacement by fibrosis takes place, tissue become completely fibrosed, shrunken, fibrosed and shrunken. That is what we call cirrhosis of the liver. Now tell me, my dear students, in cirrhosis of the liver, this is the cirrhosis of the liver. The blood is coming from this place. Will it enter really? No, not much. Then my question to all of you is that, where that blood will accumulate? कुठे साठेल ते रक्त? पोर्टल व्हेन्स मध्ये. पोर्टल व्हेन एवढी होती तर एवढी होईल. Are you getting my point? Now, my second point is very important. Now, the blood is collected by GIT moving towards the liver, and in between it is accumulated. Getting my point? This is what I am calling portal hypertension. What has developed in the patient? Portal hypertension. Clear? Now, my dear students, how is the protein content of this blood? Liver is already weak. It is being weak since long time. Now, how will be the protein content of your body? Less. How will be the content of the protein in this blood? Less. 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 कुठे जाईल ते आता? Will the protein are able to hold the fluid component, or the fluid will escape? Fluid will escape. Where the fluid will escape now? In the peritoneum. And that is how we develop cirrhosis of the liver. We'll develop ascites. Two important causes of ascites, very important. Portal congestion, portal hypertension, and hypoproteinemia of the portal vein, of the blood actually. And that's why the blood will ooze out. Blood means plasma will ooze out. Are you getting it? Portal congestion, portal hypertension, portal congestion, portal hypertension, and portal congestion, portal hypertension, and less protein content. Three important parts. And this is how the fluid will accumulate over here. Now, the portal veins are having, why every point is important. Now, the portal veins are having much blood. The blood will try to get rid of that portal veins because nothing is happening. पुढे रक्त फार जात नाहीये. तर त्या काय करतील? What the portal vein will try, the blood in the portal vein will try to find out new veins. And that new way is responsible for dilation of the vessel over the abdomen. And the vessels over the abdomen will become tortuous. Actually, it is trying to produce collateral circulation. The portal veins are trying to produce collateral circulation, and that is known as caput medusae or caput medusa. Caput medusae, caput medusa. Are you getting my point? Yes. This structure is very important. To understand the system, that is hepatobiliary system, these all things are very important. Unless you understand this concept, you will never understand portal hypertension. You will never understand how exactly ascites develop, why fluid collects. And thereafter you will tell me, Dr. Joshi, yes, in this cirrhosis of the liver, I must ask my patient to eat egg. So that is the rich source of proteins. It will help to reduce accumulation of the fluid. If your blood is going to hold the fluid, how? Protein content. आणि म्हणून त्या पेशंटला पचत नाही, पण त्याला आपण अंडे खाऊ घालतो. त्याला सांगतो की रोज 2 अंडे 3 अंडे तरी खाल्ले गेले पाहिजे, पण तुझ्याकडे प्रोटीनच नाही आहेत. Histological structure of liver. Just I have given you the idea. Now, the hepatic parenchyma is composed of the numerous hexagonal. I showed you the hexagon. hexagonal classical lobules with the diameter of 0.5 to 2 millimeters big. There are about 50,000 to 1 lakh lobules in one liver, one adult liver. One adult liver is having very high number of lobules. We talk about the lobule. A part of the lobule we have seen. Am I right? About 50,000 to 1 lakh lobules are there in the liver. Am I right? Each lobule has a central big vein. Each lobule has a central big vein radiating with 5 to 6 arc of branch of the hepatic parenchymal cells. It looks like the wheel of the cycle having 5 to 6 spokes. Very excellent explanation given by Dr. Joshi. सोपं केलंय मी त्याला एकदम. एक प्रकारे सायकलचं चाक वाटतं की नाही आपल्याला. थँक्यू.